start the session on the overview of the possible causes of unhappiness. See, we all know nowadays cataract surgery has become almost a refractive surgery, and the expectations of the patients and the promises of the ophthalmologists have become so high that any small error can cause a lot of unhappiness to the patient. So let us go through the few common complaints. One is the patient cannot see properly for far and near. Probably regarding the far, obviously since we are talking about patients with 6/6N6, it may be a residual cylinder or a small residual sphere which can be corrected with glasses, but the patient, it may be a monofocal IOL, but the patient wouldn't have been explained properly that he may need glasses even for fine far vision. Near vision, again, if a patient is not being explained to properly about the need for reading glasses in a monofocal glasses or in a aspheric lens, which is not multifocal or EDOF, the patient may say, I was not told to this before, and it creates an unhappy patient. Dysphotopsias, yes, very important, especially in premium IOLs, especially the multifocals, trifocals, and EDOFs. You can have positive and negative dysphotopsias. Can't see in normal light. This can be a complaint when you are dealing with patients who are undergoing multifocals, trifocals, etc., because the light is being split for far, near, and intermediate. So the person in his younger days must have been reading in a dark corner of the room, and he may expect the same to happen. But then you may need to tell the patient that you need more light to read after the surgery. Night driving issues, definitely because of dysphotopsias and due to other reasons. Can't see very fine print. So this is expectation versus reality. And color perception problems, especially when you have a dense cataract. Initially, you may see the primary colors, the red and the blue, more vividly. That may be a disturbance for the problem. Most of this can be settled by a good counseling preoperatively. And the other complaints, obviously, it's not just about vision. The patient can have itching, watering, discharge, etc., especially since if they are not cleaning the lids properly, or they clean the lids initially and then stop it after a month or so. They develop blepharitis. Okay. Eye pain, it could be due to a delayed post-op uveitis, or it may be just a neurological phenomenon. Photophobia, yes, definitely if the patient has got dry eye. Cat eyes, many times, especially in the spheric IOLs, not the aspheric ones, you can have this cat eye reflex when the patient moves around, and that can be disturbing to the patient. And sometimes they can say it's too bright or too dark. Too bright, especially when the patient has had a significant cataract with gross loss of contrast. And too dark, maybe in a subtle CME, etc. And so we need to deal with this by in these following headings, like the ocular surface disorders and the dry eye, which could be a very common cause of happiness. Higher order aberrations, Dr. Vanisri, I think she's on the way. She'll be dealing about the higher order aberrations. The IOL alignment, tilt, the angle alpha, angle kappa, all this will be dealt with Dr. Minu Mathan. Dysphotopsias, Dr. Matthew Kurian will be talking about the dysphotopsias. Residual cylinder, again, Dr. Vanisri. The posterior capsular opacification and capsular phimosis, this all could cause real significant problems to the patient. Dr. Sandhya will enlighten us about this. And the retinal causes, Dr. Akansha Rai will talk about it. It could be a subtle CME, the ERM, many more she'll be alluding to in that portion. So dysphotopsias can be positive or negative. Most of the time, it is because of rays of light traversing through unwanted areas of the optic, and this can give rise to a lot of internal reflection, etc., etc. Dr. Matthew is going to cover it extensively. So you can have ghosting, you can have a dark crescent, starburst, halos, And from the picture you can make out, it can be quite disabling, especially in multifocals. The early generation multifocals, you had a lot of glare, flare, halos, starbursts, or a combination, which quite a lot of is taken care of the newer generation IOLs. And this is the negative photopsias. You can see a dark crescent, temporal crescent, and the higher order aberrations. Any patients, either if we have induced a lot of higher order aberrations, or if the pre-existing higher order aberrations were very high, they can have. So all the E's can be seen, but you see, seeing the E can be different with different kind of higher order aberrations. Obviously, in the dry eye, if you have meibomitis like this, or if you have a staining like this, definitely you're going to have a lot of problem. Okay, if you look at this IOL, this lens is got a nice 0.5 to 0.7 cover of the optic. So it will take care of the effective lens position and also the centration. This also is a very well centered IOL, multifocal. But if you see this, it's not exactly what we have seen in the other picture. It's not so regular. And here again, one edge of the optic is almost uncovered. So even here, so these kind of situations, you can definitely will not have the optimum results. And here you can see a simple PC fold. This itself can cause a lot of issues. There is a double fold here, and there is a PCO here. Okay. So any patient like this, and in capsular phimosis, the patient can be very unhappy. So basically, preoperatively, you need to rule out and treat any of the causes of unhappiness like dry eye or OSD. Good keratometry, topography, and if possible, aberrometry should be done to choose the patient. OCT macula in all premium IOLs, it should be a must. Proper counseling and good chair time, and proper and correct communication and good surgical skills is very important. Postoperatively, when the patient comes to you, please evaluate the cause using slit lamp, staining, and all the investigations. Treat the dry eye if it is present and the ocular surface disorder. In residual errors, you may need to go for surgical intervention and even bioptics. Reassurance is very, very important, especially telling them that this is not going to be a progressive problem. You may have to live with it. Follow-up and proper communication is very important. Please try to follow up the patient. Thank you very much. And now I'll move on to the next part of my talk. Can you give me the next? Yeah, so I will talk about the dry eye and the ocular surface disorder. Yeah, basically, although we consider the cornea and the crystalline lens as the important refractive surfaces, the tear film, a healthy tear film, is also another very, very important refractive surface. And if there is anything wrong with this, it can cause a lot of photic phenomena, etc. And basically, dry eye is a complex disease where there is, whether it is evaporative dry eye or quantitative dry eye, there will be tear film instability, which leads to hyperosmolarity, ocular surface damage, and neurosensory abnormalities. And as you can see on the left, you have an intact tear film. On the right side, you have a broken up lipid layer, which causes osmoconcentration and apoptosis. And successful treatment is to restore the homeostasis. You could have lipid deficiency, aqueous deficiency, and mucin deficiency. Mucin, most of the time, you may not find too many number of cases, and these have to be taken care of, and the patient himself or herself will come and say they would have had some underlying disease, definitely gross disease. But aqueous deficiency and lipid deficiency are much more common. Aqueous deficiency, especially associated with collagen vascular diseases like rheumatoid arthritis, SLE, etc., etc. Lipid deficiency is the most common. And that is the one which causes the maximum damage to the ocular surface in a regular set of patients who come to us for cataract surgery. So the non-polar and the polar lipid layer gets affected, and although there is a lot of aqueous and the mucin layer is good, this breakup causes osmoconcentration and lead to the dryness. And lacrimal keratoconjunctivitis is another term which is used. You can see the broken up polar lipid layer, and through that evaporation happening and the osmoconcentration and damage to the cells. So this is the difference between a healthy surface and an unhealthy surface, leading to crenation of this thing. And in cataract surgery, we offer the patients a very painless, irritation-less surgery, and also the post-operative period, minimal rest, minimal discomfort, and it's minimally invasive. And that is the way to go. So the patient's expectations are very high. So what do we do? So how dry eye is connected to the cataract surgery? In a preoperative scenario, we either detect the dry eye during our pre-op evaluation, or you're already dealing with a patient who has dry eye. And the post-operative scenario, maybe the surgery can induce dry eye and ocular surface conditions, and or there could be a worsening of the pre-existing dry eye if you don't take care. So preoperatively, you should know it's an inflammatory disease, so that the increase in bacterial load is always there, and the poor wettability of the ocular surface. So always rule out dry eye, assess the severity of the disease, if necessary, treat, stabilize, and then only operate. And make sure the inflammation, bacterial load, and the ocular surface status is acceptable. This should be part of the preoperative evaluation. And post-operative, already we are inducing inflammation, so the extra inflammation should be taken care of. So try to avoid drugs with preservatives so that you don't cause additional damage. Make your incisions as much tolerable to the ocular surface, and hygiene of the lids is very important, intraoperatively and also post-operatively. And post-operatively, you should watch out for dry eye symptoms. If the patient complains of irritation, always try to stay in and see. Try to avoid NSAIDs if possible at that point in time. Ensure adequate lubrication and ocular surface protection, and detect the ocular surface damage and titrate the use of medication. Like I said, if already there are SPKs and the induced dry eye, then try and withdraw the unnecessary medication, then use a lot of lubricant. And detecting, basically there can be a non-obvious MGD or an obvious MGD. In both, you have to look for signs of meibomian gland dysfunction. So touching the lid, so for example, here there is telangiectasia of the lid margin, the posterior dragging of the orifices, and thick secretions. So always touching the lid margin, either with your finger or with an instrument, is very useful. So here is an obvious MGD, you don't need to think about it. And even then, you need to press and see how the secretions are, which will give you an idea how to go with. This is the non-obvious type. Still, when you press the lid margin, you can still find that it may be even a very pasty kind of secretion from the meibomian gland. So this you can do also using instrumentation like the lipid interferometry, which can give you an idea of this thing. And obviously, the Shermer is a very useful tool. But then the cotton red, phenol red thread, it's a much better and much better reproducible because it doesn't need anesthesia, and anything below 10 should be taken as to be careful. Okay, T-Butt, always mainstay, no anesthesia, no holding, and 3 checks, and anything below 5 seconds should be considered very serious and treated. And this also can be done with a video keratoscopy or even a topography to find out, look for the first black spot. In very serious cases, you may have to go for a conjunctival impression, cytology, etc. Diagnostic staining will definitely give us a clue whether it is a meibomian gland disease or it is a diffuse keratitis, etc. And staining gives you a very important. So, treating the meibomian gland, we all know, it is to improve the flow of the meibomian secretions and a normal lipid layer. So traditional treatment like warm compressors, improved lid hygiene, and antibiotic steroid combination can be very useful. But mind you, The warm compressor, etc., is only for the pre-op patient, not for the post-op. You can do intraductal meibomian gland probing. And nowadays, we have a lot of tear substitute which contain lipids. This can be very useful for the patient. Things like LipiFlow can be used pre-op. N-acetyl-cysteine helps a lot. Topical azithromycin helps. Oral omega-3 fatty acids, very, very useful. And we can also use cyclosporine. So basically, when you're dealing with it, you have to understand that you have to eliminate the inflammation also, rather than just pouring in lubricants. So basically, in aqueous deficiency, there is decreased tear volume, increased osmolarity. So your idea should be to increase the tear volume. And so we have a lot of lubricants now. The cellulose esters, among that CMC is the best. Viscoelastic polysaccharides, which increase the viscosity of the tears. That helps a lot. You have hyaluronic acid, which has got non-Newtonian properties. By this, this stick on to the damaged villi and help to heal. So that's called the non-Newtonian properties. Carbomers are high molecular weight polymers of acrylic acid. So this thin while blinking, and otherwise it stays thick and it's got a long retention time. The polyol demulcents are usually used with some others. So what are the ideal constituents? Electrolytes, lipid components, especially in meibomian dry eye. This will help a lot. Petrolatum base is not very useful other than for a night application. Osmoprotection, you can use compatible solutes like taurine, carnitine, L-carnitine, erythritol, etc. So basic idea is when there is a hyperosmotic state, there will be influx of salt. These osmotic solutes will compete with that. If the salt gets in, there will be crenation. If the osmotic solute gets in a competitive at the entry gate, then cell death can be prevented. Glycocalyxomimetic agents, which is HP-GUAR, which will mimic, the glycocalyx is what fixes the aqueous, the mucin layer to the villi. These will mimic the glycocalyx proteins. So we may need to go for cyclosporine A, tetracyclines, etc., etc. Cyclosporine, I am not going to, it's a T-cell inhibitor. Short pulse dose of corticosteroids may be needed. Tetracyclines help a long way, not only as an antibiotic, but inhibiting production of inflammatory cytokines, MMP, etc. So basically, you need to treat any baseline contributing factors, stabilize this thing. Intraoperatively, you have to use extrasteroidal precautions, lid cleaning just before surgery, maintain the cornea wet throughout surgery. Many times you forget to wet the cornea. Proper wound construction techniques, minimal surgical to the ocular surface, and proper ocular surface care, including lid hygiene, advanced lubricant. Careful watch on the ocular surface and titrating them, timely intervention will be very helpful in this kind of patient.